This video is going to show a little bit of different techniques that are required when we are in special situations, such as when the patient is in the lithotomy position and we're working off the back table. So remember, the wound classification for these cases is clean contaminated. However, we try to maintain as much sterility as we possibly can. Now, remember, the doc's going to be sitting between the patient's legs and you're going to be standing kind of to their side, and you really have to watch out for their head and their back, which are going to be unsterile when you hand instruments. And also, we're kind of working down and into the vaginal canal, which is going to dictate the function of how the instruments are going to be handed. So I'll take an avant weighted speculum. So when we hand speculums that are going to go down to the bottom, again, the blade is going to go into the vaginal canal this way. Okay. However, a right angle Heist Retractor may go above for your superior retraction. It also may go to the sides, and we'll call those sidewall retractors as well. So it's going to depend on how they're going to be positioned up at the field and who's going to be holding them in order to gain exposure into the vaginal canal. Okay. So that will dictate those. Now, we're going to have some various tenaculums and dilators that we hand. So again, these are going to be handed just like any other ringed instrument. So we'll take and we'll grab onto the cervix and go ahead and pull that forward. And then usually we'll use a uterine sound. Now when we hand these, the uterus is going to be angled this direction, so you always want the curve to be up. Okay? So we don't want to be having it angled down this way. Okay? So the doc is going to check the depth of the uterus here. They're going to take a look at the calibrations on that sound and then hand that back to you.
9, 10.
We're going to start to dilate that cervix. So when we hand up the dilators, and there's going to be various different types of dilators depending on surgeon preference, again, you want the curve to be going up, and they're going to come in two sizes. So we always hand the smallest size down or to the doc first, and then the larger size back. So sometimes we'll dip them in saline or lube before we hand them up, but they'll dilate, they'll flip it around, and they'll dilate, and then they'll hand it back.
11, 12.
And then you're going to hand up the next dilator, always telling them what size is being handed up to the field.
13, 14.
Okay. And once they get that cervical opening to the size that they need, then they're going to tell you, okay, that's enough. I think we'll go to a curette now, or whatever they're going to insert into that opening. Okay. So this happens to be an endocervical curette. We might use this to take a specimen from the endocervical area. You may hand up a telfa with this so that they can scrape that out onto the telfa. Now, when we hand up sponges, like Laura showed, sometimes we'll just lay them up here on the leg. Remember also that the doc may have a Mayo tray laying in their lap, where they may lay down instruments that are frequently utilized during the case that they may just want to pick back up. If you see a lot of instruments or sharp things laying on that tray, make sure that you grab them so that you can account for them, because remember, again, you're going to have to be counting all of those items. So a lot of times they'll grab that sponge, place it into the vaginal canal, and then once it's dirty, they may hand it back to you. All right, suture. Now, obviously, this is very, very risky to have your suture dragging someplace where it's going to be unsterile. So when it gets handed up to the field, remember, it's likely you're going to be utilizing that Haney needle holder. So again, we want that tip of the needle coming towards the surgeon's nose, but then the curve of the instrument's going to go opposite where the tip of the needle is. Now, they may either stick out their pinky and take the suture this way, or you may follow them up with the suture and kind of secure the suture up at the field, and then they're going to take a stitch, or whoever's standing up here holding retractors may take that suture from you too. But we definitely want to make sure this doesn't happen, where when it comes up, the suture is going to be hanging down below a sterile area. So we really have to pay attention to that suture. And then it'll come back to you so that you can secure it back on the field. Okay, the sponge stick into the vaginal canal, like we talked about in the abdomen, is handed where the tip is going to be down. But remember, this is a different purpose, a different utilization. So it's going to be handed this direction so that I can come into the vaginal canal, swab that area, and then come back out. So we're going to hand it to function so that the tip of that instrument is up. Okay, so let's go ahead and move on to another specialty here where we're not going to be sitting in the lithotomy position. We have some orthopedic instruments and also some laparoscopic instruments that we may be handing. Okay, now on a lot of these cases, remember, you're going to be working off a back table. You're not working off a Mayo stand, and your docs a lot of times are going to be standing, but they may be sitting if it's a hand or a foot case also. Now, A rongeur is an instrument that's going to bite bone. So there's two different ways that you can hand a rongeur, and it's really going to depend on how the doc presents their hand. So they may have it presented this way, and then we hand it similar to how a ringed instrument is going to be handed, okay? So we hand it that way, or they may take and flip their hand this way, and then it's handed upside down. Now, if you hand it this direction and you see your doc flip it around, like this to use it, then the next time when you hand it up to the field, you know that you need to be handing it like this. Okay? Now remember, your other responsibility when it comes to rongeurs or anything that bites bone is to grab a lap and clean off that rongeur as it's utilized by the doc. So they're going to bite the bone, they're going to come back to you, you're going to clean it off, and as soon as they're done, they're going to let go, and then you're going to take that instrument back onto the field. Okay, a few other orthopedic instruments. We have an osteotome with a mallet. So when we hand the osteotome up, this is going to make little cuts into the bone or osteotomies. So we'll hand this up to the field. So we always hand the osteotome first because they're going to want to make sure they position that. And then we're going to take the mallet and then tap onto the end of that osteotome. Okay, so we're breaking off a piece of the bone. After I've broken it off, I need something to grab it with. So oftentimes it's followed by a rongeur that then goes into the field, grabs the bone that I've just resected, and then we can remove it from the field depending on what we're doing. So again, the osteotome is going to come up first, followed by the mallet, that then we will tap that out, and then followed by the rongeur of some type that would be handed up to the field. A few other retractors here for orthopedics. So this is a Meyerding. When we hand this, it's going to be like any other retractor, making sure that the blade is down into the handle, or the hand into the handle so that the edge can be retracted this way. Okay. Smaller version of that, so we have the handheld Meyerding, the baby Meyerdings. Okay, so we use those in finger cases and hand cases. Handed basically the same as that, just making sure that the tip is down so that it's to function up onto the field. This is a curette, utilized to scrape off some bone in various different areas where we might be using it. So remember, it's going to be down into the wound, so I wouldn't want to hand it this direction because it's going to have to be repositioned by the doc before they can use it into the wound. Okay. Comes in various different diameters depending on how much bone needs to be removed. Periosteal elevators. This happens to be a cob. So again, it's going to be used down into the incision this direction to strip the periosteum off of the bone. I'm not going to hand it this way because the doc's going to have to reposition it before they can use it. So we want to make sure that we hand it to function so it can just be automatically utilized up at the field. This is a Heist Retractor, or sometimes called a Cricket. So when we utilize this, it's going to be like any other small, self-retaining retractor. You're just going to hand it that direction so that the blades are down and they can be opened up inside the wound. Okay, some laparoscopic instruments that we have up here. When we hand trocars, we're going to make sure that we hold on to the base, and then the head of the trocar is going to go into the palm of the doctor's hand because they're going to take and insert it into that stab wound incision that they've made. So you wouldn't want to hand it to them like this. You want to come into the palm this direction here. Remember that you also want to make sure that your stopcock is always off, which means that it's at a right angle to the opening so that you're not losing the gas in the pneumoperitoneum that you've established. Okay? So again, into the palm that direction so they can insert it through that stab wound incision. Your long laparoscopic instruments, so when we hand these, we want to make sure that the rings are going to the doc, and you also want to kind of help guide them into the trocar that they're going into. They may have two instruments and they're trying to go into trocars that are basically, it's a really long stick that the instrument is here, and it's going to be very difficult for them to insert it into that hole. So if you can kind of help guide them into that trocar, it's going to be very helpful to them. And then as they pull it out, if you kind of hold on to the trocar so the trocar doesn't work itself back out of that incision, that's very helpful as well. This is a laparoscopic probe, so again, we're going to use it into the trocar or the incision wherever it's going to be utilized. So we want to place it down this direction, and again, you can hold on to that trocar as it is pulled out as well. These are some arthroscopic instruments, so orthopedic endoscopy instruments. So again, this is just a non-disposable trocar. Very commonly we use non-disposable trocars in scopes of joints. So again, it's just going to be handed like the other disposable trocars so that we're holding the head into the palm of that hand. Again, this is a probe, so an arthroscopic probe. Again, we're going to utilize it this direction, so the tip down into the trocar where it's going to be utilized, so I wouldn't want to hand it this way because the doc's going to have to reposition it before they use it. This is a tissue grasper. There are some biters that look very similar to this as well. But on these, we call these pistol grip types of instruments. When we use these, you're just going to hold on to the shaft and hand them into the palm of the doc who's going to take them. If they're a biter of some kind, you're going to grab a sponge and be ready to clean off the biter as well as they utilize it up at the field. And then when they're done, they're going to release, and then you'll take the instrument from them. Not so much this tissue grasper, but there's another instrument called a pituitary that the doc may utilize in this type of a position. So when they utilize that up at the field in this type of a position, and then it comes back to you, next time you hand it up to the field, make sure that you hand it upside down. Okay, so again, like we talked about, if you see them switch the rondure around, next time you hand it up, make sure that you hand it in the position in which it's being utilized up at the field, and then make sure that you're ready with that sponge to clean off the instrument as they utilize it.